All right, welcome once again, and I'm going to share the screen with you. We will start with Hodgkin lymphoma today, and in the next session, we will do non-Hodgkin lymphoma. So I hope you can see the screen. Is that correct?
Yeah, clear, sir.
All right, thank you very much. So this picture gives you some idea of what Hodgkin lymphoma is. Lymphomas are cancers, solid cancers of the immune system, in which most of the times the lymph nodes are involved, but the spleen could also be involved over there. All right. So let's start with Hodgkin lymphoma. And Hodgkin lymphoma is a potentially curable lymphoma. That's the good news at the very outset. So we have got very good results with treatment. It is characterized, one, by microscopic appearance and expression and cell surface. So there are two things. Actually, there's a specific type of cell which is known as Hodgkin-Reed-Sternberg cell. And if you find that, that confirms the diagnosis. But there are also some specific cell surface markers, which include CD15 and CD30, as I'll show you. So an excisional biopsy and histologic evaluation is always required for diagnosis. And in classical Hodgkin lymphoma, the neoplastic cell is Reed-Sternberg cell, which we write it as HRS, which stands for Hodgkin-Reed-Sternberg cell. So in the whole tumor, just 1 to 2% of the cells are Reed-Sternberg cells. They are large cells with multiple nuclei. I'll show you in one of the slides. The remainder of the cells are composed of a variety of reactive mixed inflammatory cells consisting of lymphocytes, plasma cells, neutrophils, eosinophils, histiocytes, which include macrophages or dendritic cells. All right. So quite a mixture of cells. And this also shows you that it is a disease of the immune system. So Reed-Sternberg cells are large abnormal lymphocytes that may contain more than one nucleus. For pathologists, it is very easy to identify these cells after preparing the slide and after properly staining those cells. Most Hodgkin-Reed-Sternberg cells are of B cell in origin, and they are no longer able to produce antibodies. We all know that the B cells, they are sort of produced in the bone marrow, they mature in the bone marrow, and then they have got certain cell markers. They have got IgM and IgD antibodies on their surface, and they have got some other cell surface markers, which include CD19, CD20, and CD21. And over here, or in the next lecture, when we will do non-Hodgkin lymphoma, CD20 cell surface marker is going to be important, okay? So they produce antibodies when they are exposed to the antigen. They start producing antibodies, and when they start producing antibodies, they are known as plasma cells, which die after 2 weeks. They go on producing hundreds of thousands of antibodies, or they can take another route. Under normal situations, they can become memory cells. But anyway, let's come back to Hodgkin lymphoma. The Hodgkin-Reed-Sternberg cells express CD30 and CD15 cell surface markers. CD30 is expressed by malignant lymphoid cells, and CD15 is not normally expressed by B cells. And because, these tumors, most of the times they arise in the lymph nodes. So we'll have a quick revision of the anatomy of the lymph node. So this is what a lymph node is. There are afferent lymph vessels, many of them, and one is efferent, from which the lymph flows out. So lymph will flow in from these afferent lymph. Then it has got a cortex, which is this sort of darker green. And it is the area where we find B cells and follicular dendritic cells, and subcapsular macrophages. All of these are antigen presenting cells. And in the paracortex, which is sort of light green, we have got T cells and dendritic cells. Okay. And actually, follicular dendritic cells, they are a bit different. We have got antigen presenting dendritic cells, which present antigens. Okay. Right. And then we have got primary follicle. When the B cells start dividing, they become germinal centers, and that's where most of the lymphomas start growing. Okay. So, and it also shows you the arteries, because the cells, when they're formed in the bone marrow, they'll be released into the bloodstream and they'll come through the arteries and they will exit the veins through what are known as high endothelial venules. Okay, that's where they exit. Also in inflammation, the immune cells extravasate from these high endothelial venules. And this slide shows you a typical Reed-Sternberg cell, which is a large cell. If you compare it to other lymphocytes present over here, big cell and with multiple nuclei. Okay, and the nucleus of a resting lymphocyte is slightly larger than an RBC. So this is an RBC and this is the nucleus, but this is quite out of proportion as far as the size of the cell is concerned. Here is another picture. You see many Reed-Sternberg cells over here. This is one over here. So anyway, this is for the pathologist to make a decision. But what I want you to remember is that in Hodgkin lymphoma, we have got 1 to 2% Reed-Sternberg cells in the tumor. And we also have got some specific cell surface markers, which are CD30 and CD15. Now, Hodgkin lymphoma is classified into many different types that I'm going to show you in this slide. The two main subdivisions are classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma, which are just 3 to 5% of all Hodgkin lymphomas, right? So they are not very common, but the treatment is different in case of nodular lymphocyte predominant lymphomas. Okay. Now, this classical Hodgkin lymphoma is divided into other subtypes, which include nodular sclerosing, which are 60 to 80%. Then we have mixed cellularity, 15 to 30% of all Hodgkin lymphomas, lymphocyte depletion less than 1%, and we have got lymphocyte-rich Hodgkin lymphoma, which is 3 to 5%. Okay. So this is the division or classification that I expect you to know. In these cases, most of the times we have got certain protocols that are more or less the same, and I'll come to those protocols. Right. Now, in this slide, there is a brief description of the subtypes of Hodgkin lymphoma. I'm not going to read that, but through this description, you'll understand the differences. I've highlighted the most important point. For example, nodular sclerosing is most common. It has got large tumor nodules. We have got classic Reed-Sternberg cells. Then we have got other cell types as well. There is quite a lot of fibrosis and sclerosis in this one, and it is observed most frequently in young adults. Then the other cell types, I want you to read it on your own. Okay. Now, this one, nodular lymphocyte predominant Hodgkin lymphoma, is distinct from classic Hodgkin lymphoma and is characterized by presence of popcorn cells which express CD20, right? So that is why we give in treatment, we give an antibody which is known as rituximab, which is anti-CD20 monoclonal antibody. And if you remember, it has got this C in it. Nomenclature of these antibodies is based on certain things, whether it is they are derived from mice or what percentage of mice portion does it have, what percentage of human portion does it have? So we have not gone into the details of the nomenclature of monoclonal antibodies, but maybe you'll do that in your tutorials, okay? So due to these differences among other non-Hodgkin lymphomas, it is often treated differently from classic Hodgkin lymphoma. So that's one important point that you have to memorize. Right, etiology, it is unknown, unfortunately. Many studies have shown that up to 30% of cases of classical Hodgkin lymphoma are positive for Epstein-Barr virus. And this means that 70% are not positive, but they are still Hodgkin lymphomas. Epstein-Barr virus positivity is most common with mixed cellularity variant. HIV positive patients have a higher incidence of Hodgkin lymphoma than HIV negative patients, okay? So decline in immunity or poor functioning of the immune system is associated with development of lymphomas. And of course, lymphomas are more common in those patients who are taking immunosuppressive therapies. And about 1% of Hodgkin lymphoma have family history, so etiology is not very clear. Siblings have got an increased risk. Nodular sclerosing type is heritable with 100-fold increases in risk in identical twins. HLA class 2 genotype are known to be associated with this NAS, this one, nodular sclerosing Hodgkin lymphoma. And single nucleotide polymorphisms in genes associated with immune function have been shown to be associated with nodular sclerosing type, right? So it is not very clear. There are many things that we know are associated with Hodgkin lymphoma, but we are not very clear, although we are quite sure that there are many cases which result from Epstein-Barr virus infection. Now, epidemiology, I've given you a link over here. We know that the cases have been falling over the last 10 years, but epidemiology, I will not go into a lot of details. I've already given you the percentages of different types of lymphomas. Unfortunately, there are more in males than in females. Sex predilection is more pronounced in children, with 85% cases affecting boys. That is for Hodgkin lymphoma. As far as age is concerned, it has got a bimodal distribution, which means where there are two age ranges in which it is very common. One is, of course, in childhood, or you can say young adults, 15 to 34 years. And the second peak is after 55 years. Native Americans, for some reason, they have got a lower incidence. Prognosis is very good. We have already seen that, okay? Stage 1, only originating in 15%, 92% 5-year survival. Stage 2, 40%, 93% 5-year survival rate. Actually, it's more, I am not sure whether it is a mistake, but anyway, it should be less than that, but it's written 93%. I'll double check this. But anyway, the survival rate is very good. And stage 3 is 83%, and stage 4, which has metastasized, still 73%, and unstaged 82 to 83%, right? So 5-year survival rate is very good. And international prognostic system, most commonly used variables for giving a score, for obtaining a IPS score is, we give 1 point to each variable, serum albumin. If it is less than 4, we give 1 point. Hemoglobin less than 10.5 gram per deciliter, we give 1 point. Male sex, 1 point. Age more than 45 years, 1 point. Stage 4 disease, 1 point. And WBCs more than 15,000, again 1 point. And absolute lymphocyte count less than 600, or less than 8% of total WBC. So again, Each one of them have got 1 point. Okay, so now the 5-year survival rate depends as these points increase, the prognostic factors increase in number, the survival rate decreases in number. Okay, so that's what you have to understand. This part is very important. You have to know the prognostic factors. Now, patient education is also important, because once the patient gets lymphoma and he is given treatment for that, then he remains at risk of developing other cancers. Okay, before beginning treatment, patients should be counseled about potential complications of therapy, including risk of cardiac disease, lung toxicity, secondary cancers. And patients should be informed about potential loss of fertility. That is a problem, particularly, I've seen that, I've shown you that it is bimodal. It's more common in 2 age groups. One is younger patients, okay, 15 to 24 years or 29 years. So if those are, particularly if those are girls, then this loss of fertility is a serious issue. And we have got certain things to preserve the fertility of those patients. We can do sperm banking in case of males. Oral contraceptive use is one option. And oophoropexy, whatever you call it. Some people call it oophoropexy, or I don't know exactly how to pronounce that. But anyway, what you do in this procedure is that before radiation therapy begins, ovaries and fallopian tubes are separated from the uterus, and they're attached to the wall of the abdomen, where you will, which will be away from the radiation. If you have got lymphomas in the inguinal region, then obviously you have to give radiation over there, and radiation therapy is an important part of treatment in Hodgkin lymphoma. So that is what you're doing before you start radiation therapy. You separate them from the uterus and you attach them to the abdominal wall on one side. Okay. Now, loss of fertility may arise from MOP therapy or escalated BCOP therapy. I'll show you all these therapies, and you have to memorize all the drugs that are in these therapies or protocols. And we have got irradiation as well. Then regular breast self-examination is important for patients, because if they have got some chest disease and they have been given radiation in the chest, there is a possibility that the female or the woman might develop breast cancer. So breast self-examination is important. Then risk reduction for cancers and cardiovascular diseases. The patient has to decrease or quit smoking and decrease lipid intake and decrease the use of sunscreens to protect from, or use sunscreens to protect from skin cancers. Then some patients undergo splenectomy, which is not very common, but once a patient undergoes splenectomy, then he is predisposed to developing infections. Okay, so that is a serious issue in patients with splenectomies. Clinical presentation Hodgkin disease is usually almost confined to 3 groups of lymph nodes, and the most common is in the cervical region. Asymptomatic lymphadenopathy above the diaphragm in 80% of the cases, right? So asymptomatic means there are no symptoms, no pain, nothing. As I showed you in the title slide, there might be a swelling over there. So then I'll show you a little more of the distribution. But this B symptoms are very important. Okay, these B symptoms, they include 3 things: weight loss, more than 10% of total body weight within the preceding 6 months, or unexplained fever, which is more than 38 degrees Celsius, and drenching night sweats. They are present in 40% of the patients. So B symptoms are important. And they are also indicative of an unfavorable disease that I'll show you later on. Then Bell-Epstein fever is a very specific type of fever that is there in most of the cases. About 35% of the cases of of Hodgkin lymphoma. This fever is specific because it appears for 1 or 2 weeks, then it will disappear for 1 or 2 weeks. It will return for 1 or 2 weeks, okay? So that is what keeps on happening. Then mediastinal mass of lung that can lead to chest pain or shortness of breath or cough. Pruritus, which means irritation on the skin, that could be present. The patient will be scratching his skin. A pain at the site of nodal disease, which is precipitated by drinking alcohol. Okay, so that is something quite unusual. That is present in 10% of the cases, and why that happens, I'm not sure why that happens. Family history. So all these things are there in the clinical presentation of that. Physical examination, a palpable painless lymphadenopathy can be seen in cervical area. 60 to 80% is in cervical area. Then axilla, which is the armpit, 60 to 20%, and inguinal area, 6 to 20%, right? So this is the most common distribution, although, Hodgkin lymphoma can appear in any other lymphoid organ. And that includes everywhere, involvement of Waldeyer ring or occipital or epitrochlear, which is in the arm. I'll show you in the next slide. They are infrequently observed. Waldeyer ring is there in the throat. It includes lingual tonsils and palatine tonsils and tubal tonsil, adenoid, all these lymphoid. These are all lymphoid tissues. Splenomegaly, hepatomegaly might be present. Superior vena cava syndrome, if the tumor is large in the chest or in the mediastinum and it is pressing on the superior vena cava, it will slow down the blood flow. CNS symptoms could be there, this Guillain-Barré syndrome or Guillain-Barré, whatever the pronunciation is, which is an autoimmune disease which destroys the neurons, okay? So all these could be the clinical presentation, or you can find all of these in the physical examination of the patient. And then again, a distribution, in the red, I've given you the regions where it most commonly appears, but it can appear anywhere in the body, it has been given over here, right? And this slide is obviously for your reference only. Now, again, differential diagnosis is for your reference only: cytomegalovirus, Epstein-Barr virus, non-Hodgkin lymphoma, SLE, and small cell lung cancer, tuberculosis, sarcoidosis, right? Many of these things. And then sometimes patient may present as homophagocytic syndrome, which I've given you the details over here. There is phagocytosis of hematopoietic cell, pancytopenia, fever, right? So this slide is for your reference. We will not go into a lot of details, okay? Because we are not directly concerned with this. Now, workup is important. I've said that staging is always important in all the cancers, and biopsies are important. So accurate staging is critical in deciding the ideal Hodgkin lymphoma treatment plan. And the factors that are required for staging are imaging modalities, sampling, which is biopsy, assessment of prognostic factors that I have already shown you, and complete blood count and blood chemistry. You have to keep a baseline of all these tests, because as the treatment progresses, we have to monitor how these baseline tests are changing, okay, or the baseline values. Lab test, CBC is there. ESR is very important. A very high ESR is a poor prognostic factor. Lactate dehydrogenase, now bulk of the disease or the size of the tumor is important. Serum creatinine obviously is indicative of renal function. Alkaline phosphatase, if the bones or the liver are involved, and you have to test for HIV as well. So this is more or less the workup. And then imaging studies, PET is becoming, positron emission tomography has become very important. Now that we have mentioned previously as well that it's not available in every hospital because that is a very expensive piece of equipment, okay? So imaging studies are important for accurate staging of Hodgkin lymphoma, and they include plain X-rays, CT scan, PET scans, and bulky disease imaging studies can identify bulky disease which has prognostic implications. Bulky disease means that the size of the tumor is more than 10 centimeters, or if it is in the chest, it is more than 1/3 of the thoracic diameter, okay? 1/3 of the thoracic diameter. Now, CT scan of the chest can identify enlarged lymph nodes or pleural effusions or lung nodules or infiltrates, right? And this is a CT scan which shows you the right lung and the left lung, okay? This is, it's a big tumor, big lymphoma over here. And we have got, this is vena cava and this is trachea. Everything that is black means there is air in it. And ascending and descending aorta, just to give you some information on CT scans. So as I said, PET scanning can distinguish between viable tumor and necrosis or fibrosis and residual masses that are often present after treatment. So PET scanning is important. It is now considered essential to the initial staging of Hodgkin lymphoma. Now, PET scan can be combined with CT scanning, which is known as fusion scanning, and it can also be combined with MRI scanning, okay? We have got machines that combine these two images and they will overlay the images on each other. So we'll not go into the technical details. It uses a special type of glucose, which is known as 4-deoxyglucose, which has got radioactivity. It is known as a radio tracer. And then we have got this PET machine that will detect, okay? So like in this patient, you're seeing that the black arrows, they indicate the involvement of the lymph nodes, and the red arrows shows the bone marrow involvement. So bone marrow involvement is another problem, and it is a sort of a serious issue in lymphomas. Okay, so a lymph node, again, as I said, biopsy is essential because the pathologist will look for Reed-Sternberg cells and he will stain for the CD markers over here. Fine needle biopsy is the initial step and it is followed by excisional biopsy. Bone marrow biopsy could be done. We are doing the biopsy of the lymph node first, whichever is the swollen or the enlarged lymph node. And if indicated, we have to do more investigations. If indicated by the PET scan, or the patient is old, or the disease is advanced in stage, the histology is high risk, then we can go on to bone marrow biopsy, okay? Some experts feel that bone marrow biopsy can be omitted in the early stages, which makes sense. Pleural effusion, you can do sampling of the pleural effusion, which is known as thoracocentesis. You draw fluid from the pleural space and you look for cancer cells in that. We do that in lung cancer as well. We saw that in the previous lecture. And CNS evaluation has to be done, although the involvement of CNS is very rare, okay? Now, staging, I've given you briefly, nothing much in this staging. It's not complicated in cases of both Hodgkin and non-Hodgkin lymphoma, right? So it is known as Ann Arbor classification. Stage 1, a single lymph node area or single extranodal site contiguous with the lymph node, just next to the lymph node, that is stage 1. Stage 2, 2 or more lymph nodes on the same side. Now, you see, this is important to note that we are looking at the diaphragm, whether the disease is on one side of the diaphragm only, or it is on the both sides. If one lymph node on one side of the diaphragm, stage 1, 2 or more lymph node areas, same side of diaphragm, stage 2. If you have got involvement on both sides of the diaphragm, then it becomes stage 3. And you know that stage 4 is metastatic disease, okay? Involvement of liver or bone marrow or some other tissue, okay? Now, in the staging, we also look at the extension, which is known as contiguous extension. If the tumor is in the lymph nodes and it goes into the tissue right next to the lymph node, we call it an extension into the other tissues, okay? And also remember that spleen is considered a part of this lymph nodes, or if the tumor is there in the spleen, it is also the same as a tumor in the lymph node. So when the contiguous extension, which means out of the lymph node, for example, in the lung parenchyma, actually it says that direct extension of mediastinal node into adjacent lung parenchyma is not considered stage 4, right? It is considered an extension, but not a stage 4. Stage 4 is metastasis non-contiguous. It is away from the lymph node, okay? It is not joined to the lymph node. So an extension is designated E. For example, stage 2BE extended into the contiguous areas. Involvement of spleen is denoted with S. So this is something with nomenclature. Spleen is considered to be a lymph node area, as I explained to you. Now, A and B designations denote the absence or presence of B symptoms. A means absence and B means presence of B symptoms. And X designates bulky disease, and bulky disease means larger than 10 centimeters or 4 inches in size, okay? So this slide is important. You must know everything that is there in this slide. Now, again, Lugano classification, same thing that I have shown you, stage 1. This shows you stage 1, localized disease, single lymph node, region of the single organ. Okay, so it is on one side of diaphragm. If it has extended to a contiguous area, we call it 1E, stage 1E, okay? And has spread to one area outside the lymph node, but it should be contiguous. Then stage 2 are on the same side above the diaphragm, 2 lymph node regions, or below the diaphragm. Now, not on both sides. Okay, either both are below the diaphragm or both are above the diaphragm. We call it stage 2, or it will be stage 2E if it has extended to the adjoining area. All right. So stage 2 is 2 or more lymph node regions on the same side of the diaphragm. Now, stage 3 is on 2 sides. You know, one is above the diaphragm and one is below the diaphragm. Or you see stage 3, 2 or more lymph node regions above and below the diaphragm. So both of should be present, or there is lymph node involvement above the diaphragm and spleen involvement below the diaphragm. Again, it is above and below the diaphragm. So we call it stage 3. And again, it could be 3E. And if it is spleen, we will call it stage 3S, which means spleen is involved. And stage 4 is obviously, it has gone to the liver over here. It is in the lungs, but not contiguous. Okay, it is separate from the lymph node. And, you know, it is going into above and below and other tissues over here. So bone marrow will be involved. So liver is involved, okay? Lungs might be involved. Brain is not very common, but it could be involved, right? So this is the classification, and I hope it is clear to you. Now we go on to the treatment, and the treatment is a little bit complicated. Again, there are 3 or 4 protocols that are there, and there are some drugs, and there are some differences in those protocols. But there is one protocol which is known as ABVD, which is the most common protocol. Okay, the others are backup protocols, or if this protocol doesn't work, or if there is some contraindication to this protocol ABVD, then we use the others. So the goal of therapy, because the 5-year survival rate is very good, our goal is to achieve complete remission. In cases of failure to achieve remission, salvage therapy is there. There are certain protocols. Our treatment modalities include radiation therapy, which is always given in Hodgkin lymphoma in combination with the protocols that I'll show you in the next slide. Induction chemotherapy is the therapy that you start with, and it induces a remission. Then after induction chemotherapy, we sometimes give maintenance chemotherapy. Salvage chemotherapy, you have given treatment and the treatment has regressed. The patient is in remission, but it comes back, it recurs. And now when it recurs, the therapy that you give after recurrence is known as salvage chemotherapy. And this is a very specific treatment for Hodgkin lymphoma, which is known as hematopoietic stem cell transplantation, which are of two types. You can have autologous from the person, or you can have a donor for that as well. And again, treatment will be tailored for each patient. The treatment is going to be individualized. We have to assess the patient completely, age, risk of short-term toxicities, risk of relapse. In general, the management of Hodgkin lymphoma depends on the subtype, okay? And not only on the subtype, also on other factors like early stage disease or late stage disease, favorable or unfavorable, bulky or non-bulky, okay? So many things are taken into account, and we decide whether to give intense high-dose therapy or intense radiation therapy. CRT stands for chemoradiotherapy, okay? Advanced stage disease is treated with chemotherapy alone, right? Staging and risk estimation. Staging is based on Ann Arbor classification that I've already shown you. Then again, we have got further subdivisions, which are early favorable, stage 1 or 2 with no unfavorable factors. So what is favorable? Which has got no unfavorable factors. What are unfavorable factors? I'll show you in a minute, okay? Now, we have got early stage favorable disease, early stage unfavorable disease. Then we have got a non-bulky disease and a bulky disease. Early stage unfavorable, stage 1, 2 with bulky disease, okay? Then we have got advanced stage, which is stage 3 or stage 4. And here are your unfavorable factors, which are for here, which is ESR of greater than 30, presence of B symptoms, more than 3 nodal sites of involvement, the size of the tumor. 4 and 5, they both show you the size of the tumor. If it is in the mediastinum, then if it is more than 1/3 of the thoracic diameter, okay, then it is known as large, greater than 0.33%. And bulky disease is more than, they are both bulky diseases, more than 10 centimeter in any dimension. So that is known as bulky disease. Now, international prognostic score is defined by the number of adverse prognostic factors present at diagnosis. The more negative the prognostic factors, the worse is going to be the prognosis, okay? And the scoring system helps in clinical management. So that I'll show you in the next slide. And patients are divided into scores 0 to 2 and 3 or more than 3, okay? 3 or more than 3 is negative, more worse prognosis, and 0 to 2 is good prognosis. Right, so favorable disease, again, I've written over here that it is for your reference only. So we have already seen what favorable disease is. It is absence of unfavorable factors, okay? We call that favorable disease, and it is good. And if these unfavorable factors are present, we give 1 mark to each, and we see whether it is 0 to 2, less dangerous, 3 or more dangerous, okay? Right, so again, they have given some favorable or unfavorable factors, German Hodgkin Study Group and European Organization for the research and treatment. So any patient with early stage disease who does not meet either the above criteria, is considered to have early stage. No, it should be early stage unfavorable disease, okay? He meets these criteria. Or sorry, once again, who does not meet, it's correct. It does not, who does not, no more than 2 sites, which means less than 2 sites. No extranodal extension is a good thing, okay? No bulky mediastinal disease is a good thing. ESR less than 50 or less than. So if these things are not present, then it's bad. So it is unfavorable, okay? Right. Now, toxicity will always be there because of the medications we use. We have got short-term toxicity based on regimen, and we have got chemoradiation therapy. I think in 2 or 3 minutes, we are going to take a break. So short-term toxicity based on regimen and modalities. Modalities means whether it is chemotherapy or radiation therapy, most of the time it is combined. So it could be hematologic toxicity. The patient can get anemia, thrombocytopenia. Sometimes the anemia could be so severe, particularly when the bone marrow is involved, that there could be a need for transfusion. All right, neutropenia could be there. Pulmonary toxicity, particularly if you use bleomycin, which leads to pulmonary fibrosis, and that is irreversible, okay? A cardiac toxicity in case of anthracyclines, adriamycin or doxorubicin, which is a part of ABVD regimen. Even this bleomycin, is a part of ABVD regimen. Then toxicity can be fatal. Then we can get long-term facilities, myelodysplasias or leukemias could be there. Pulmonary toxicity could be lung cancer. Fibrosis of the lung is a risk factor for lung cancer, particularly in smokers. We have seen that in lung cancer chapter. Okay, then congestive heart failure could develop as a result of doxorubicin. Breast cancer as a result of chest irradiation for mediastinal tumors, okay, and neurological toxicities, right? So we will take a break over here. I will stop recording and we will come back after, let us say, 10 minutes so that we quickly complete this lecture and then we will be free to go, all right? So I will pause the recording over here. All right, so I hope everyone is back and you had a good cup of coffee in the break. It's draining to have a 3 hours lecture, but if we give it a little push in the beginning, then we will be better off towards the end of the semester, okay? So we are doing very well so far. Some of these difficult chapters we will try to cover in quizzes. Like I said that we have to cover 3 chapters in quizzes. So I think this lymphomas, Hodgkin and non-Hodgkin should be one of those lectures that we will cover through quizzes, okay? But it depends how many lectures are we able to cover before the midterm examination. So that is one thing. And the second thing is that I have heard that we are going to get the building back very soon. I'm not sure whether that's true or not, but if it is true, then that is very good news. We will have some place to go and some place to sit, okay? Right, so let's continue with the lecture, and I have turned on the recording. Right, I've resumed the recording. Right, so this was all about treatment toxicity, and now we go on to radiation therapy. Radiation therapy is often administered in combination with chemotherapy. It is known as involved site radiation therapy, ISRT. It is the most commonly used radiation therapy in lymphomas. And radiation field includes pre and post chemotherapy nodal volumes, and plus a 1 point, how much area are we covering by the radiation? That is what we mean by radiation field. So let us suppose that the cancer is 1 centimeter, but we will give a radiation not 1 centimeter, but an area outside that 1 centimeter, 1.5 centimeter outside. So our total area will be about 4 centimeters, a circle of 4 centimeter, right? With a diameter of 4 centimeter. That is what it means. So radiation field includes pre and post chemotherapy nodal volumes plus. So after chemotherapy, the volume decreases. So our area of radiation will also decrease, okay? Other radiation therapies involved field radiation therapy, INRT, involved node radiation therapy, and that is the field of radiation oncologist. Now, induction chemotherapy regimen, now this is where the treatment starts, and this is where you have to know all the things. It is a must to know. For example, if it is MOP regimen, you have to know that it is meclorethamine and ongoing vincristine or procarbazine, prednisone. You have to know these acronyms or these protocols and the drugs in these protocols. You don't have to know the doses, okay? You have to know the names at least. ABVD, the most famous and the most common regimen that is applied, doxorubicin. The brand name is adriamycin. Then you have got bleomycin, and we have seen the adverse effects in the previous slide. This causes heart damage, cardiac insufficiency. Sometimes it is permanent. Bleomycin, lung fibrosis, that too is permanent, and it can lead to lung cancer or severe compromise of lung function. Vinblastine, again, a vinca alkaloid that could cause neuropathy, and the carbazine. Then we have got this A plus AVD, brentuximab vedotin. This is a newer drug. It is commonly used when we do hematopoietic stem cell transplantation. And these common, I hope now you know these drugs. You have done these in pharmacology as well. So doxorubicin, vinblastine, dacarbazine, and Stanford 5, it is not V, it is Stanford 5. It is spoken as Stanford 5. So it includes doxorubicin, vinblastine, and mustard, bleomycin, vincristine, etoposide. I'll show you these drugs once again. And we have got BCOP, bleomycin, etoposide, doxorubicin, cyclophosphamide. You see, it starts with BA, and vincristine. The brand name is Oncovin. So vincristine is written as O. It has been written as OO here as well. Procarbazine, prednisone. So that is how there are just 4 or 5. So I hope it will not be difficult for you to memorize these, okay? And this, you see, it is written, this table is very important. This gives you a summary of the drugs, which in most cases is ABVD that I show you in the previous slide. And the same thing that I will show you in this slide, I'm going to repeat that in the next few slides, okay? So this slide is important because it is a summary of the treatment in different stages, a classic Hodgkin lymphoma, 1A, favorable disease, unfavorable disease, non-bulky, bulky, and then the advanced stage of the Hodgkin lymphoma. So ABVD, now what is the difference? Favorable, unfavorable, bulky, non-bulky. It is the number of cycles. We have got involved site radiation therapy in all of them. They're written over here, okay? And we have got ABVD in all of them, but it is the number of cycles that are different, okay? You see 2 cycles over here, 4 cycles over here. In this, we have got 2 cycles plus another 2 cycles plus ISRT. And for advanced stages, we have got 6 cycles. And I've given you doses over here, but I don't expect you to memorize the doses. If you memorize them, it's good. Otherwise, you can keep them for your internship or your rotations. Same as above, then comments additional cycle may be added based on results of restaging and PET-CT scanning. So you give this therapy, and if the lymphoma recurs, then you can add more cycles, or we have alternative chemotherapeutic regimen which are given over here. All right. So Stanford 5 ABVD alone, we have got this radiation therapy, or we have got BCOP. I'll show you once again in the next slide. Again, alternative therapy is Stanford, from 8 weeks over here, it has gone to 12 weeks over here. Okay. And similarly, from BCOP, we have gone to BCOP escalated BCOP, 2 cycles followed by ABVD. So you see the dose that is becoming more dense. Okay. And the doses are sort of increasing. You'll understand that when I show you the next slide. Again, 12 weeks for Stanford 5 and BCOP escalated 2 cycles followed by ABVD, more or less the same thing. Patient above 60 years, they're high-risk patients. So we give a more intensive therapy in those patients, right? So this slide is a very good slide. If you read from this slide, what I am going to show you in the next 4 or 5 slides is the same thing that is given in this slide, okay? Now, before I go on to those few slides through, I'll go very fast through them. This is Stanford 5 and doxorubicin, and the dose is also given over here per milligram per meter square. Vinblastine, meclorethamine, which is nitrogen mustard, most probably, and vincristine, bleomycin, etoposide, and prednisone. And these are the drugs. So what is the difference between these two? I've given you, many of the drugs are common between Stanford 5 and BCOP that you have seen, okay? Doxorubicin is here, doxorubicin is here, etoposide is there, etoposide is here, bleomycin, vincristine. So what is the difference? These are the abbreviations used for different drugs. For doxorubicin, we usually denote it by an A, adriamycin. But anyway, this is given over here. Vinblastine, meclorethamine, not present in BCOP. Okay, they are present. Vinblastine, meclorethamine are present here, but not in BCOP. And cyclophosphamide and procarbazine not present in cyclophosphamide, and procarbazine not present in Stanford 5. And this is, we have got BCOP and we have got BCOP escalated. So what is the difference? The difference is in some doses. And which doses I've given you over here? Etoposide 100 milligram per meter square, it is 200 milligram. Doxorubicin 25 milligram, it is 35 milligram. Cyclophosphamide 650, 1250. So that's the difference. Okay, this is all you have to know in this slide. And most of them are given intravenously. Okay, there are just 2 drugs that are given orally, which are cyclophosphamide and vincristine. No, vincristine is not given orally. That is a mistake. I must correct that. Okay, prednisone is given orally. Cyclophosphamide is not given orally. So for the moment, there is a mistake over here. Please ignore this for the moment. All right. I'm going to correct that. Okay. So now, after this slide, we will come back to what I've shown you in this previous slide. Okay. Right. So now we go on to hematopoietic stem cell transplantation. Here is what we do. This is autologous hematopoietic stem cell transplantation. So in step 1, we administer a pre-treatment to release blood stem cells from the bone marrow. Okay. Then we collect those blood stem cells and we freeze them. Okay. Then we give myeloablative chemotherapy to destroy the bone marrow. And obviously, once we destroy the bone marrow, the patient is under a very high risk of getting infection and even dying from those infections. So we have to have a very specialized facility in which there is a higher pressure inside and lower pressure outside, okay, so that nothing comes in from outside. Then the next step is we return the thawed blood stem cells by infusion into a vein, and we provide supportive medical treatment for at least 4 weeks as the immune system rebuilds, okay? So this is what you do. You preserve or you take out the stem cells, bone marrow stem cells, you freeze them, you destroy the bone marrow and the immune cells, and then you re-inject those stem cells. So autologous, the same cells from the person come back to him, okay? Myoablative chemotherapy, high dose therapy given according to beam regimen. Now, I've given you doses over here, but you don't have to memorize the doses. You just have to memorize the drugs. For example, you have bendamustine, you have etoposide, you have cytarabine. For cytarabine, instead of C, they have written A because the other name for cytarabine is Ara-C, okay? Cytosine arabinoside. So that is what the other name of the drug is. Melphalan. So what are we doing with this regimen? We are destroying the bone marrow and the immune system, and then we will rebuild it from the cells from the same person, okay? And this is something negative sign means before the stem cells are administered. Okay, this is that was autologous, and this is from another person, from a donor. So same procedure, and then we give the cells from the donor and they develop in the patient, okay? So brentuximab vedotin is indicated as consolidation therapy. So we have an induction therapy, and then we have a consolidation therapy, which further consolidates the treatment outcome, okay? Following autologous hematopoietic stem cell transplantation in patients with classic Hodgkin lymphoma who are at high risk of relapse or progression, right? So this is a newer drug, brentuximab vedotin, The regimen is 4 to 6 weeks after autologous hematopoietic stem cell transplant. And the doses are given over here 3 times weekly for up to 16 cycles, or until disease progression, which means that you are giving the therapy, but the disease is still progressing, which means the therapy is not working. So you will stop that, or the toxicity becomes unacceptable or not tolerable by the patient. Right, so this is an allogenic transplantation, and the previous one was autologous transplantation. Allogenic means it comes from another person. Autologous means it is coming from the same person. Right, now stage 1 and 2, same what I've shown you in the table. Let's go quickly. Combined modality therapy, chemotherapy, ISRT, chemotherapy is ABVD 2 cycle for favorable disease. Stanford 5 for 8 weeks. It was either 8 weeks or 12 weeks with radiation therapy. ABVD alone. For younger patients, you can give it alone. Younger patients have got a better performance status, so better outcome. And Wheel score is this is something which has to do with the radiologist. This is a PET, positron emission tomography. Deauville or Deauville. It's a French word, so I don't know how to pronounce that. So this was stage 1 favorable, stage 1 and 2 unfavorable. Now we have got 4 cycles. Here it was 2 cycles. Now we are going on to 4 cycles with radiation. All right. Again, we have got Stanford 5 and BCOP and ABVD. These regimens do not demonstrate significant differences in response rate, failure-free survival, overall survival, okay? So, but as you have seen in that table, ABVD is our treatment of first choice. Then stage 2, non-bulky disease, 4 cycles, Stanford 5 for 12 weeks with radiation therapy, and additional 2 cycles of ABVD if required, okay? So again, I would recommend that for all these slides, the easier way is to go to that table. after reading this slides. We go on to stage 3 and 4, classic Hodgkin lymphoma. And there is a landmark randomized controlled trial which has compared these three MOP regimen, ABVD regimen, and MOP alternating with ABVD 6 cycles, which means here you give only MOP regimen for 6 to 8 cycles, right? Whatever the protocol, whichever dates you give. ABVD 6 to 8 cycles. This one is a little bit different because you give 1 cycle of MOP regimen, 2nd cycle of ABVD regimen, then 3rd cycle of MOP regimen, and 4th cycle of ABVD regimen, and so on. Okay. So what they found was ABVD alone or alternating with MOP was superior to MOP alone. So that is why ABVD is better than MOP. So we use ABVD most of the time. Other regimens that are included in the guidelines are BCOP, BCOP escalated, Stanford 5, okay. ABVD is preferred. We have seen it in that table. Dose intense regimens such as BCOP escalated may be considered in patients who are above 60 years of age and whose prognostic, international prognostic index is equal to or more than 4, right? So I think everything is clear in this slide. Now patients above 60 years, we have to give them intense therapy. Classic Hodgkin lymphoma is associated with poorer outcomes in older patients due to combination of aggressive disease, medical comorbidities. You know, these older patients, they have got heart problems, they have got hypertension, they have got diabetes, they may have got some lung diseases, particularly those who have been smokers. They may have atherosclerosis, they may have chronic kidney disease. You know, with old age, the body function declines and more diseases are afflicting the individual. So dose reductions are required in standard chemotherapy due to toxicity or treatment-related mortality in these patients. So we have a problem in these patients, right? The outcomes are poor. The toxicities could be more than younger people. Their performance status is not good, and they have got many comorbidities or diseases, okay? So selection of first-line therapy should be individualized with goal of minimizing toxicity and maximizing efficacy. Again, bleomycin, lung fibrosis, suggested treatment regimen, radiation therapy. Involved site radiation therapy is an option for systemic, is an option if systemic therapy is not considered to be feasible or safe. So all of these are showing that the outcome is not very good in people above 60 years of age. Okay, right. Management of classic, again, you know, nothing different. ABVD or AVD with radiation therapy. CHOP. This is, I guess, a new one for you. Again, cyclophosphamide, H for doxorubicin. Actually, it is hydroxydoxorubicin. So we have seen 3 letters for doxorubicin. We have seen A, we have seen D, and we have seen H, all mean doxorubicin. Then vincristine, Oncovin is the brand name, and prednisone, okay? So another new therapy, and I'm sorry about that because this is what the treatment is, and you have to know that, at least for the purpose of this semester. When you go to your ward again, you'll have to come back to these. All right, so this is just another regimen, but you know, you can guess which drug it is. If you read them a few times, you will come to know that, you know, vinblastine, cyclophosphamide, prednisone, procarbazine, etoposide, and what they stand for, these alphabets, okay? So stage 1 to favorable disease, stage 1 to unfavorable disease, almost the same. The number of cycles has increased, okay? CHOP regimen 4 cycles and 6 cycles over here, okay? And then we have got another regimen for unfavorable disease, and this one with ISRT, more or less the same thing. Okay, now we go on to salvage. We have given the treatment, the patient went into remission, He was fine, he was well, but the disease came back. The patient has relapsed. And or the disease is refractory, which means that we are giving the treatment, we are giving induction treatment, but the patient is not going into remission. His cancer is a bit too sort of tough, not responding to medications, okay? So the goal is cure. Majority of relapses following a complete remission occur after completion of the therapy. But the prognosis is poor because the disease is now more resistant to therapy, okay? And basically chemotherapy fails because the cells are, they have so many mutations that they are resistant to treatment, okay? So options for treatment: second line chemo, high dose, autologous stem cell, and strong radiation therapy, all of these therapies. This is a strong radiation. It will help. It might not cure the patient. Our goal is to cure the patient. So we might achieve our goal in some cases, and we might not achieve it in some cases, okay? Radiotherapy, if not previously given, platinum-based therapy, carboplatin, cisplatin, oxaliplatin. We have seen that in previous lectures. And chemotherapy regimen include brentuximab, vedotin, ICE, sorry for another regimen, ifosfamide, carboplatin, etoposide, DAP regimen, okay? Regimen. You see carboplatin, cisplatin are now coming in, and SHAP regimen. Okay, so this mostly involves memorization, so I'm not going into details. Now, this is a new drug, brentuximab vedotin. This is used for maintenance therapy for 1 year following autologous stem cell transplant for patients with primary refractory disease. Refractory disease means a sort of disease that is not responding to therapy. Okay, disease relapses in less than 12 months. Additional options include bendamustine, everolimus, which is, you might have done that previously, used in many cancers. Lenalidomide, if you remember, thalidomide was a sedative drug that was used in 60s in Germany, and it caused a lot of birth defects. The boys were, or the children were born without their limbs, So this belongs to the same group, thalidomide, okay? And it is also used in many cancers, and it has got multiple mechanisms of actions. Now, immune checkpoint inhibitors for relapsed classical Hodgkin lymphoma, nivolumab and pembrolizumab. I'll show you their mechanism in the next slide. So Reed-Sternberg cells overexpress PD-L1 ligand. So what's the problem with this? PD stands for programmed cell death ligand. What is this ligand doing? Okay, so in 65 to 100% of the cases, it is expressing this ligand. Now, as I'll show you in the next slide, this ligand inactivates the immune cells, the T cells, or the cytotoxic T cells, the natural killer cells that are attacking the cancer cells. It inactivates those cells. Epstein-Barr virus increases the expression of this ligand, programmed cell death ligand. And outcome in poor old people is not good. Then we have got options for palliative therapy. If nothing works, then we give palliative therapy. We can give bendamustine, we can give brentuximab vedotin, and we can give radiation therapy. So this is the mechanism of action. You see, this tumor cell is expressing a PD, this is PD-L1, programmed cell death ligand. And this is the programmed cell death receptor on T cell. When the tumor cell has got this ligand, like it is written that 65 to 100% of Reed-Sternberg cells have this ligand, they inactivate the T cell and the tumor grows, because the T cells, whichever T cells, natural killer cells or cytotoxic T cells, they bind through MHC complex the cancer cells, they cannot kill it. They are inactivated. So the tumor grows. But when we block this receptor, with pembrolizumab and nivolumab, okay, these two drugs. When we block these receptors, then this interaction will not take place. The ligand, PDL ligand, will not inactivate PD receptor. So the tumors, the T cell will not be inactivated. It will remain active. It will kill the cancer cells, right? You got the point? If the PDL1 or PD ligand 1 is active, present on the tumor cell, it will inactivate the T cell. If you block this ligand with the drug, then the T cell will not be inactivated. The cytotoxic T cell or the natural killer T cell, they will not be inactivated. They will remain activated. They will kill the tumor, okay? Right, so that this slide is also included, okay? And I think this is the last slide. I don't know, I'm not sure, but if not last, this is the second last slide, okay? Now we have got this cancer. You know, we said that this cancer, which is nodular lymphocyte predominant Hodgkin lymphoma, nodular lymphocyte predominant Hodgkin lymphoma, NLPHL, it has got a different treatment. All right, and what different thing does it have? It has rituximab, okay? Again, we have non-bulky, we have got bulky disease. In non-bulky, just observe and give radiation, which is preferred. In bulky, you give chemotherapy. I've shown you all those chemotherapies, ABVD, CHOP, CVP, whatever they are, whichever you want to use, and you use that with rituximab because these cells express CD20. And when rituximab binds CD20, then rituximab is going to invite the cytotoxic T cells. With the help of this antibody, the cytotoxic T cells will recognize the cancer cell and they will kill the cancer cell. Okay, that is known as antibody-dependent cytotoxicity, antibody-dependent cellular cytotoxicity, ADCC, antibody-dependent cellular cytotoxicity. Okay, so that is what rituximab. I'll show you the mechanism of. Actually, I've shown you this mechanism of action in pharmacology. Okay. And then stage 3 or 4, which are the advanced stages, almost the same therapy, same as above, okay? And HIV treatment, for HIV, we have to give treatment for HIV as well, okay? We have to give heart therapy, highly active antiretroviral therapy, okay? Which includes nucleoside reverse transcriptase inhibitors, protease inhibitors, non-nucleoside or viral fusion. We have done all this in virology. And complications are cardiac disease, pulmonary disease, secondary cancers, infertility. We have some ways, some procedures to protect the ovaries that I've shown you, okay? And infections, particularly with the splenectomy, although splenectomy is done very, very rarely. And we can get autoimmune problems with nivolumab and pembrolizumab. And that is all. So I'm glad that we are over with today's session. It was quite a lengthy session, 2.5 hours. So if you have any questions, you're welcome to ask me the questions if you are there. And if you don't mind, please write your names on the chat so that I know that all of you are awake. Good. Muhammad Hadi is awake. That is very good. We have got a lot of people who are still there. All right, is that all we have? Let me see. All right. Okay, so if there are, I'll have a look at these names later on. If you have no question, then we will call it a day.
Doctor, how many lectures in total we have in this semester?
10 lectures. I gave you the distribution in the first lecture, Yeah, we will have three, we'll cover 3 lectures with quizzes, 3 in midterm examination and 4 in the final. Okay,
So we can take a Hodgkin lymphoma for third quiz.
yes,
Because it's
I think
happy
we will
subject,
do-
you know, doctor.
we have more of Hodgkin, you know, we have got today we did Hodgkin lymphoma, next time we are going to do non-Hodgkin lymphoma. So this is the most difficult lecture in cancers or among the cancer lectures. Okay, so I think
That's why we are planning to take them in the quiz, doctor, to remove it from midterm, if you can, please.
yes, so we'll do a quiz from this lecture, okay? But we'll not do it this week. We'll do it next week or sometime after that. We will ask Al Walid to fix a time for the quiz, okay? But first we have to complete these lectures, okay? Anything else? All right.
Thank you.
Thank you very much.
No, thank you, doctor.
Okay. See you next time.